for taking time, actually on her day off, to present to us. We really, really appreciate that. Dr. Gewaily is an experienced retinal surgeon who joined Lancaster Retina Specialist after several years in private practice in Philadelphia. She served as an adjunct faculty at Penn State Eye Institute as assistant professor of ophthalmology, where she enjoyed teaching Penn residents and fellows both medical and surgical retina. She specializes in the broad medical and surgical management of diseases of the retina and vitreous, with a particular interest in the treatment of macular degeneration, retinal vascular disease, including advanced diabetic retinopathy, macular hole and pucker, and complex retinal detachments. And if there's anything else you'd like to add before you get started, please feel free to do that. Thank you.
No, thank you for the gracious introduction, and thank you everyone for taking the time out of your schedule to hear about retinal surgery.
Excellent. Before I turn it over to her, I will mention again, if you're not a client with us here at Vision Corps, we have a lot of other fantastic services here. In addition to presentations like this one, we'd love to talk with you more about our services and how we can assist you to achieve independence and a quality of life, again, that might be impacted by your vision loss. And again, we'll provide information on that at the conclusion of our presentation today. So Dr. Gewaily, I'll turn it over to you.
Okay, thank you once again. So let me just have my outline up. Okay. All right, so as Ms. Greth mentioned, I'll be talking to you about retinal surgery, which is obviously a very broad topic. I'll give a broad introduction of retinal surgery, indications for retinal surgery, how we perform it, and at the end, we'll have a question and answer session. So I'll aim to speak for about 45 minutes or so, and then we'll leave about. I thought this would be a good topic to discuss because most people have not heard about retinal surgery, specifically vitreoretinal surgery, unless he or she requires it or has a friend or family member who requires retinal surgery. So I thought it would be an interesting topic to discuss. We perform different types of retinal surgery, but the primary surgery that we perform every time we're in the operating room is something called a vitrectomy, which is also referred to as PPV for short, pars plana vitrectomy. The pars plana specifically refers to a part of the eye that is void of blood vessels, so it makes for a good place to perform incisions so that we don't get bleeding in the eye. So I'll either refer to it as vitrectomy or PPV for short. So as I mentioned, I'll discuss how the surgery is done, where it's done, how we numb the eye, most importantly, why we do the surgery. I'll leave a portion of the talk to discuss what the recovery of surgery is like, potential complications, and then we'll leave a brief section on the future of retinal surgery. For each discuss the symptoms of the disease, when we decide vitrectomy is a good idea, and what you can expect in terms of success rate. So a little bit about the history of vitrectomy. So it's widely considered that the first closed vitrectomy was performed in 1970 in the United States by a physician by the name of Dr. Robert Mockamer. And the indication for surgery was a chronic bleed in the eye in a diabetic patient. And keep in mind, 1970 was before the advent of the injections, the VEGF inhibitor injections that we give every day in the office to treat a wide variety of diseases such as diabetes, wet macular degeneration, retinal vein occlusion, so on and so on. 1974, the same doctor was performing macular surgery or surgery in the center of the retina with bent needles. So obviously we've come a very long way over the decades in terms of how vitrectomy is performed. Vitrectomy is usually performed in an outpatient surgery center. It can also be performed in the hospital and less commonly in a surgical suite within the office. It is outpatient surgery, meaning the patient is in and out the same day. There's no need to spend an evening in the hospital. Most vitrectomies are performed under what we call MAC anesthesia. MAC stands for monitored anesthetic care. Of course, we complement the MAC anesthesia with a block. A block means that we numb the eye. So the surgeon at the start of the surgery will inject a little bit of lidocaine around the eye. The patient does not remember this part because the anesthesiologist will sedate the patient. And what the numbing does is it not only prevents the patient from feeling anything during the surgery, but it also temporarily paralyzes the eye muscles for a period about 6 hours, which obviously covers the length of the vitrectomy, but also provides some pain control for after the surgery. The patient also needs to be able to lay flat for about an hour, give or take, depending on the reason for the vitrectomy. Longer cases, or cases that require what we call a scleral buckle, which I'll get into later in the talk, will generally require the patient to be placed under general anesthesia. So if a surgery is going to be 1.5, 2 hours or longer, general anesthesia is probably the way to go. It is still outpatient surgery, so you can still expect to leave once you're recovered. In special circumstances, we may no anesthesia at all with a block to the eye, but that is the exception rather than the rule. So as I mentioned, most vitrectomy is performed in an outpatient surgery center, but that is assuming that the patient is healthy enough to undergo outpatient surgery in a surgery center. So this determination is generally made between the family doctor and the anesthesiologist. If a patient is deemed to be what we call ASA 1, 2, or 3, then the patient can have surgery in the surgery center. With regards to blood thinners, and many of our patients take blood thinners, I usually like the patient to stop the blood thinners before a vitrectomy. And of course, this is done in conjunction with the family doctor, the cardiologist, or whoever the prescriber is. And the purpose of this, of course, is to decrease the risk of bleeding in surgery or after surgery. However, I will ask the patient to resume their blood thinners the evening of surgery in almost all circumstances, the evening once the surgery is complete. Aspirin is generally okay to continue. I don't have a problem if a patient continues aspirin, as the risk of intraoperative bleeding is minimal with aspirin use. So as with any surgery, the patient has to be what we call NPO, nothing by mouth, for at least 8 hours prior to surgery. And as I'm sure many of our clients here have had previous surgeries, you know, you'll generally be called the evening prior with a time to arrive to the surgery center. It's usually about 1 hour prior to the start of surgery. Again, you're fasting. You gown up, the nurse will dilate the pupil of the eye that we're operating on, and then you get wheeled into the operating room. So at that point, we numb the eye, as I discussed. Then we do what's called a prep. We clean around the eye, quarter of the face, in order to get rid of bacteria around the eye to minimize the risk of infection. Then the patient has a drape and they lay flat for about an hour or so. The surgeon then brings the microscope over the dilated eye and begins what's called a standard 3-port vitrectomy. So what do the 3 ports stand for? So basically, there are 3 incisions in what I refer to as the pars plana, the area of the white of the eye where there's not too many blood vessels, and we insert these ports or trocars, which are, the way to think about it, little tiny cylinders that allow for easy entry in and out of the eye. And these have become much safer over the years because they have valves which allow easy entry of instruments in the eye, but they don't allow for egress of fluid from the eye. So it allows for a safe, controlled vitrectomy in a closed system with a controlled eye pressure. And that has really been a huge advancement in the surgical retina field. In terms of what each port is designed for, our very important port is for the infusion. So basically, we have this infusion line that is connected from the vitrectomy machine to the eye, and it is constantly infusing fluid in the eye because, again, we need to control the eye pressure. So as the surgeon is removing vitreous gel, which is the point of the vitrectomy, the infusion is constantly supplying pressure to the eye. Another trocar allows for the insertion of a light pipe. So this allows for the surgeon, of course, to see what he or she is doing in the back of the eye, because of course it's dark in the back of the eye. We have the microscope allowing visual see. And then the workhorse of the vitrectomy surgery is really the vitrector, which does most of the work. It cuts the vitreous and it allows us to do whatever other steps are necessary for the surgery. And I'll go over how vitrectomy varies based on the different indications for retinal surgery. But that's a general setup of the 3-port vitrectomy. It's actually quite nice for the surgeon. The surgeon is seated the entire time. The shoes are off. The reason being, a retinal surgeon actually uses both his and or her hands and feet to perform the surgery. So it requires the use of both the right and the left hand equally, and then one foot controls the pedal of the controls a pedal that controls the microscope, and then the other foot controls the functions of the vitrectomy machine. So it's really a very active surgery that requires both hands and feet. It's a very delicate surgery, so you actually don't need big muscles to perform such retinal surgery. It's really requires very small, careful movements on the level of not even millimeters, but rather microns, which is a fraction of a millimeter. So all vitrectomy will involve what we call a core vitrectomy, which is removing the bulk of the vitreous gel. At a bare minimum, a pars plana vitrectomy will involve the removal of the center gel. Oftentimes, we'll also perform what's called a shave vitrectomy, which is removing the edges of the vitreous gel. And then additional steps after that depend on the reason for the vitrectomy. And I'll go over several indications of a vitrectomy, which I think would be of use to our patients. At the end, of course, we remove the trocars, and often the sclera or the white of the eye are self-sealing. Occasionally, we'll have to close the incisions with a dissolvable suture, which, as the name implies, will go away on its own after about 4 to 6 weeks. We'll inject antibiotics and steroids at the end of the surgery under the surface of the eye to, again, calm down inflammation and decrease the risk of an infection. Drops, ointment, and a patch are then placed over the eye. The patch stays on overnight, and then the patient is generally seen in the office the following day, at which time we remove the patch and we give the patient instructions. Eye drops are started the day after surgery, and if there's any positioning requirements, and again, I'll go over which surgical indications we have a patient position for, the positioning would then start immediately after surgery. So with modern small gauge vitrectomy, which is how we refer to this, using valved trocars, vitrectomy has really become a lot faster, a lot safer as compared to when it was first performed in 1970. It's both easier and faster for the patient and the surgeon. And, we've come a long way, which is nice. So now I wanted to spend the bulk of the talk talking about indications or reasons for a vitrectomy. So the biggest indication is retinal detachment. Retinal detachment in the general population is actually quite rare, happens in about 1 out of 10,000 people. But of course, for a vitreoretinal surgeon, we see retinal detachments on a weekly, if not daily basis. So I will spend a lot of time on retinal detachment. Generally, there are three types of retinal detachment. One out of the three is actually not a surgical problem. So the first type I'll discuss is something called an exudative detachment. And exudative detachment just means a fluid underlying condition. Usually the treatment for this type of retinal detachment is to treat the underlying condition. So whether that is severe high blood pressure or kidney problems or a tumor in the eye causing fluid under the retina, the treatment is the underlying cause. By definition, there is no retinal break in this type of retinal detachment, and therefore treating the underlying cause usually results in resolution of this type of retinal detachment. The second type of retinal detachment I'll discuss is called a tractional retinal detachment, which involves the formation of scar tissue on the retina that cause the retina to pull off. So, like exudative detachment, there is a long list of different causes for tractional retinal detachment. I would say the most common cause for a tractional retinal detachment is advanced diabetes, diabetic eye disease, or diabetic retinopathy. Diabetes, as I'm sure you're all aware, is a very common disease in the United States. And diabetes affecting the retina is actually the leading cause of blindness in the middle-aged working population. And the most advanced type of diabetic eye disease presents as a retinal detachment. So, believe it or not, not all diabetic retinal detachments require surgery. If the detachment involves the edges of the retina and the patient is relatively asymptomatic, we can just observe. Of course, we treat medically, perhaps with injections or laser, but we don't have to go to surgery if the tractional diabetic retinal detachment or tractional detachment of any cause is just involving the edges of the retina. However, if the scar tissue involves, then the patient's going to be very symptomatic, probably in the legally blind range, and we have to go in and surgically repair those types of retinal detachments. Also, if a tractional retinal detachment leads to a break in the retina. So now you have two types of retinal detachments. You have what's called a tractional retinal detachment, and then you have what's called it's a mouthful, rhegmatogenous retinal detachment. So if you have this combination retinal detachment, then we go in and do surgery. So those would be the exceptions. In which case, leaving it alone would just make things worse. The most common type of retinal detachment, however, the bread and butter detachment that you may be most familiar with, is the rhegmatogenous retinal detachment, which means there is a break in the retina that caused the retina to pull off. The most common cause for this type of retinal detachment is the formation of a vitreous detachment. And I spend a lot of time in the office explaining to patients every day what the difference between a vitreous detachment is and a retinal detachment. A vitreous detachment is a normal age-related phenomenon. So if I had to pick an age in which the vitreous detachment forms, it's most commonly around age 60. Of course, people get it earlier, people get it much later. I've met 80 and 90-year-olds who still haven't developed a separation of the vitreous, but most commonly it's in the 60s. And this occurs because of a normal age-related phenomenon in which the vitreous gel becomes more liquid-like as we get older. And it can form clumps here and there, and the patient could have some floaters as they age. However, when the vitreous becomes so liquid-like that it pops off the back of the eye, we call this a vitreous detachment, or the official name is PVD. Means it's in the back. And most of the vitreous detachments are uneventful. The patient can be quite symptomatic in the beginning. The symptoms are floaters and flashes usually. And then with time, usually these symptoms subside. So the floaters never go away, but the flashes, if they occur, usually get better. However, in 10 to 15% of people with a vitreous detachment, a retinal tear can form. Why is that? Because the gel, the vitreous gel, pulls so hard that it tugs the retina and creates a break in the retina. And I compare the retina to wallpaper. So if you have a little tear in on your wallpaper, the wallpaper can slowly start to peel off. The retina is the same way. The retina is sort of like the wallpaper in the back of the eye. So if the vitreous gel pulls too hard and creates a break in the retina, then the retina can start to peel off. So that is the most common type of retinal detachment, the rhegmatogenous retinal detachment. Sometimes a retinal tear or break can form and the eye can just heal itself. And those patients are lucky, of course. However, certain types of retinal tears, if they go untreated, have a very high likelihood of progressing to retinal detachment. So it's very important for anyone who develops a sudden, I use the two words sudden or obvious increase in floaters or flashes to call their eye doctor and be seen within 24 hours. Um, Retinal breaks, if they're caught early, are relatively easy to treat. They're treated in the office with either a cryopexy or laser retinopexy. So you're either going to freeze the break or you're going to laser and wall off the break. If a break is treated in the office, the recovery tends to be relatively straightforward. A patient can fly. They can generally resume all their normal activities like exercise, things that require the eye to move quickly, like excessive reading, for about 1 to 2 weeks. Both cryopexy and laser pexy work well in treating retinal tears. Sometimes, however, either the patient doesn't present quickly enough or the retina pulls off despite presenting quickly. If some retinal detachments can be treated in the office. So if a retinal detachment meets certain requirements, we can perform an office procedure, which is called a gas pneumatic retinopexy. Which is a two-step procedure that involves treating the retinal break with either laser or cryopexy, so laser or freezing, and then we also inject a small gas bubble into the eye. There are certain benefits to this in-office gas pneumatic retinopexy. For instance, the patient recovers vision a lot more quickly if it works. There's less chance of cataract formation, and I'll discuss cataract formation and vitrectomy later on in the talk. You don't need the systemic anesthesia, so there's no general anesthesia or monitored anesthetic care. It's done in the office, it's quick to perform, so on and so forth. So there are a lot of benefits um, if we can perform a gas pneumatic retinopexy. However, there are also downsides. According to the literature, the success rate of an in-office gas pneumatic retinopexy is lower as compared to performing a vitrectomy in the operating room. We don't remove floaters using this technique because, as I mentioned, it's two steps. You treat the break and you put a gas bubble. You don't remove the vitreous gel, which is what creates the floaters. So the floaters will remain. And then positioning for the patient is a little bit more challenging because we inject a smaller gas bubble in order to fix the retinal detachment. So correct positioning is very important. However, if a gas pneumatic fails, I personally go straight to vitrectomy. I don't do repeated attempts at another gas pneumatic retinopexy. And performing a vitrectomy after a gas pneumatic is not technically challenging. As long as the patient is followed closely and you go to surgery promptly, the prognosis should be just as good. So that is just a way I wanted patients to be aware of fixing a retinal detachment in the office. However, most retinal detachments with a retinal break are repaired with the pars plana vitrectomy. In terms of the procedure, as I mentioned before, of course, you numb the eye, you prep the face, you have the drape on, the patient's positioned flat on the back. Then we insert the 3 trocars, again, that 3-port vitrectomy that I had mentioned. Of course, we're going to do the core vitrectomy. So we're going to remove the floaters and the gel. The gel is what created this problem to begin with, because the gel pulled hard and tugged on the retina and created a break. We spend a lot of care removing the vitreous overlying the area of the retinal detachment, because we want to relieve traction. We want to eliminate that pulling. And we even go so far as to take the vitreous cutter and amputate the retinal tear. And it's amazing how much traction is relieved with this maneuver. You could actually see the fluid coming out from under the retina and the retina starting to flatten while doing the vitrectomy. So once we identify the tears, and this requires careful examination under the microscope visualization, we mark the tears. So we mark with something called an endodiathermy. So again, we're entering one of those trocars and we're marking all of the tears. This allows the surgeon to visualize the tears well and laser all the tears so that we don't have any redetachments. So if you recall, one of the trocars allows for the infusion of the eye during the vitrectomy. So instead of a sterile saline infused into the eye, we then switch to an air infusion. So air slowly goes into the back of the eye and flattens the retina while the surgeon is sucking fluid from under the retina. So now the vitrector has been put aside and you have an extrusion cannula that sucks fluid from under the retina while air is going into the eye. Now you have a flat retina and you're very happy. The retina is attached and you're on the home stretch here. The surgeon takes a laser. So again, there's a light pipe in one hand so you can see the back of the eye. There's a laser in the other hand and you treat all the tears. Now, why do patients have to position? I'm sure patients have heard about the gas bubble and having to position after retinal detachment surgery. The reason is laser takes, both laser and cryo, and you can do cryo intraoperatively as well, take about 1 to 2 weeks to form a scar. So you laser all the tears, the laser hopefully scars down the tears, and in conjunction with a good postoperative positioning, the retina stays flat. However, we typically don't leave air in the eye because air is a type of gas that goes away pretty quickly. It disappears in about 1 to 2 weeks. So the issue is if the air goes away in a week, but the laser hasn't scarred for 2 weeks, the retina can redetach, which of course we don't want. So then the final step of retinal detachment repair is what we call an air-gas exchange. So at this point, we vent air from the eye. The infusion, which initially had saline and then air going into the eye, then starts to push gas into the eye. So the air is removed, gas is put into the eye. Sometimes, interestingly enough, what gas do you put in the eye? So it's typically one of 2 types of gases. For those who are chemistry minded, we're either going to put C3F8 in the eye or SF6 in the eye. The interesting part is that we have to put a specific concentration of gas into the eye. The reason being, if the gas is too concentrated, the gas will expand in the eye, and that could lead to a dangerously high eye pressure and vision loss. If the concentration is too low, then the gas goes away too quickly, and once again, the retina can redetach. So this part I always do in the operating room because I feel like it's very important. So I will titrate the gas to either being 14% C3F8 or 20% SF6. I usually use C3F8. Once the eye is filled with gas and the retina is attached and we have laser in place, we are done. So we remove the trocars, we suture the eye as needed, we put the drops, the ointment, the patch. If the patient is able, I actually will have the patient position right then and there just to get them into the habit and realize the importance of post-operative positioning. Positioning is interesting. It actually depends on where the tears are. because what happens is gas or the other tamponade agents that we use typically float up. So for instance, if we worked on a left eye and the tears were on the left side, I'm going to have the patient lay on his or her right side because the gas will push up against the tears, the laser will scar, the gas will slowly dissipate on its own, and then hopefully we're left with a nicely attached retina. Um, Positioning is always a stressful thing for patients, and I understand. It's a lot of work. It limits what you can do for 2 weeks after retinal freedom to be in any position he or she wants for 10 minutes out of every hour. So it's not a completely around the clock thing. It's you do get 10 minutes out of every hour to run to the bathroom, to take a quick shower, to do whatever it is that you have to do. However, the other 50 minutes out of the hour has to be, in a position. And you can walk because, of course, we don't want patients to develop blood clots or be completely immobile for 2 weeks because that's not healthy either. So you can walk and be in the correct position if necessary. Gas is interesting in that it places 5 restrictions on the patient until the gas resorbs. And those 5 restrictions are no flying in an airplane, no scuba diving, which always gets a laugh out of patients because my patients are not typically avid scuba divers, but I have had some scuba divers, so that's important. No going up elevation 2,500 feet or higher. No obtaining nitrous oxide, which is sometimes given in dentist's office, and you also cannot undergo hyperbaric oxygen treatments, which is not a common issue that patients run into, but is very important to keep these 5 restrictions in mind. These are not permanent restrictions. This is just for approximately a 2-month period until the gas is completely resorbed. Any of these activities, particularly a major change in altitude or atmospheric pressure, can cause the gas to expand, which again, as you can imagine, can be very unhealthy or dangerous, cause elevated eye pressure and vision loss. So it's very important that the patient abides by these 5 restrictions. Now, typically we put gas in the eye for retinal detachment repair, but we also have the option to put other tamponade agents or agents that are going to push the retina back into place. The other more common agent in some eyes who would benefit. So typically I reserve an oil tamponade for the more complicated retinal detachments, recurrent retinal detachments with scar tissue. If a patient needs to fly in an airplane, then oil is a valid option because you can fly and have oil in the eye. Oil does not expand the way gas does. Also, if the patient is monocular, meaning we are operating on his or her only eye, then oil is generally the way to go, because when gas is in the eye, the patient actually cannot see much of anything because the eye is not designed to see through gas. So a patient would have to hold his or her hand up really close to see the 5 fingers, whereas oil gives you somewhat more ambulatory vision. So again, reserved for the monocular patients. Also, if a patient has a little difficulty with postoperative positioning, oil may be a better option. Again, I still like patients to be compliant with an oil tamponade, but it gives us a little bit more wiggle room. So unlike gas, which slowly resorbs, oil stays in the eye until we go in and perform another vitrectomy to remove the oil. Usually that is done somewhere within 3 to 6 months from the primary vitrectomy. Okay, so we spent a lot of time on vitrectomy for retinal detachment. We do have a couple other tricks up our sleeve to repair retinal detachment. Sometimes we do what's called a combination vitrectomy and scleral buckle. So a scleral buckle, I like to compare it to a belt. So it's a silicone band that we put under the surface of the eye and specifically under the eye muscles. And it acts like a belt in that it brings the eye in and it helps support the retina while we also help attach the retina from the inside. So you have two forces working together to help reattach the retina. We reserve the combination vitrectomy and scleral buckles, again, for maybe the more complicated retinal detachments, recurrent retinal detachments, scar tissue detachments that involve the bottom part of the retina, because again, with gas resorbing and going up, you may want more coverage of the bottom part of the retina, so on and so forth. Since this is essentially performing two surgeries in one, it's usually a minimum of 1.5 hours. So it's best that the patient be under general, especially with the scleral buckle involving a little more manipulation. We like to put patients asleep for this type of surgery. The recovery is manageable. There might be a little bit more post-operative discomfort, but in my experience, usually Tylenol or Motrin is sufficient. I don't remember the last time I've had to prescribe a narcotic for a vitrectomy patient or even a sclerobuccal patient. So the discomfort is not too bad. Sometimes we will do a primary scleral buckle, and the most ideal candidates for such a surgery to repair retinal detachment are the young patients, in their 20s and 30s, perhaps 40s, who have a retinal detachment without the vitreous detachment, which is a possibility. So I said vitreous detachment is the most common mechanism to develop a retinal detachment, but you can have retinal detachments without that vitreous separation, and sometimes performing just the scleral buckle is sufficient in those patients. Okay, so the last portion of retinal detachment I wanted to discuss was the tractional retinal detachment. So again, this is a retinal detachment that's formed due to scar tissue formation. And I had mentioned diabetes as a common cause for tractional at play in this type of detachment, because you don't necessarily have to have a defect or break in the retina for the retina to pull off. So vitrectomy is definitely the mainstay surgery in repairing these types of detachments. You perform that core vitrectomy, remove the gel in the center, but then you spend a lot of time peeling the scar tissue. And this can take a while because it requires delicate maneuvers. You cannot just take the scar tissue and pull it off. That could be very damaging to the retina, especially in these eyes that have sometimes not the greatest blood flow. They could be very fragile. So you actually have to spend your time and remove the scar tissue, cut, gently pull, cut, dissect, and this can go on for an hour or longer. However, once you feel like the scar tissue has been removed, then you flatten the retina, the air goes in the eye, laser, and typically a gas bubble with positioning afterwards. Okay, so you may be wondering, what is success rate for retinal detachment repair? The literature cites a little bit of a range, anywhere between 85% to over 95% for your bread and butter retinal detachment with a couple of breaks. No significant scar tissue and that sort of thing. I'm not talking about the advanced diabetic detachments, just your normal retinal detachment. So we definitely aim to fix a retinal detachment in a single surgery. I tell all my patients in the first 3 months that we have to monitor carefully. Most people do well and are fine. However, if scar tissue is going to develop, it is most likely to develop within 6 to 12 weeks after surgery. And this happens in about 10% of retinal detachment cases and can cause redetachment. So there are certain factors developing scar tissue. If a detachment is chronic and there was pre-existing scar tissue at the start of the first surgery, then scar tissue may be more likely to form. If there was a lot of blood in the eye with retinal detachment, that would increase the risk. If you have multiple retinal breaks, that would increase the risk. A giant retinal tear, meaning a tear that extends 3 clock hours or more, can increase the risk of the scar tissue, so on and so forth. Trauma, smoking, young age male, So, I tell my patients to be cautiously optimistic. If a retina remains attached through 3 months, then we're usually in very good shape. I have seen late onset retinal redetachments, but they're by far the exception, not the rule. So how well do people see after a retina has been successfully reattached? It depends. If this ideal scenario is that the center of the retina never came off to begin with, in which case the prognosis is quite good. We really should be able to get the vision back to where it was before the detachment started. However, if the center was detached, meaning the center is the macula, if it's a macula off retinal detachment, the prognosis varies, and it depends on how long the macula was detached, so on and so forth. But generally, we get the vision significantly better than it was before the retinal detachment. Okay, so I know retinal detachment is a big topic. That's all I have to say at this point, but of course we can certainly go back to it, retinal detachment, the question and answer session. Next, I wanted to move on to macular hole. So macular hole is another indication for vitrectomy. This also occurs because of an abnormal pulling of the vitreous gel on the retina. However, instead of a hole in the center of the retina. So the macula is the center of the retina, and typically a macular hole occurs at the fovea, which is the center of the macula. Now, the mechanism for macular hole formation is an abnormal pulling from front to back, but also can be due to an abnormal pulling side to side. So there can be a wrinkle formation that then splits the retina at the weakest point, which is the center of the macula. There are 4 stages of macular hole. You can have a partial thickness macular hole, which can be relatively asymptomatic. So if it's partial thickness and the patient has no symptoms, then there is no role for a vitrectomy. You observe. You give precautions, advise the patient that if you do start to have vision changes, blurred vision in the center, to call promptly. However, when a macular hole becomes full thickness, then surgery is indicated because the chance of spontaneous macular hole closure is only like 10% or so. Whereas vitrectomy to treat your typical macular hole has about a 95% or higher success rate. So I like for my patients to present promptly. Symptoms of a macular hole would be blurred vision in the center, wavy lines, a drop in vision. Who's at risk for a macular hole? For unclear reasons, women tend to develop macular holes more commonly than men. If a patient is very nearsighted, because the eye is typically more elongated, there's more pulling from front to back, and they can be at a higher risk of developing a macular hole. Trauma is a risk for macular hole, advanced diabetic disease, inflammation. Macular hole can also be associated with a retinal detachment. So either the macular hole caused the retinal detachment, or this is definitely an indication to perform a vitrectomy. So the treatment is primarily surgical, as I've been hinting. However, sometimes in the case of a very small macular hole, I may try drops. So sometimes anti-inflammatory drops, specifically steroid and aspirin and eye drop form, can reduce some of the swelling around the hole and get small holes to close, in which case that is obviously the best case scenario. Traumatic macular holes in kids sometimes can spontaneously close, and those definitely have to have a period of observation before pursuing surgery. I have been able to close some macular holes with steroid injections around the eye. However, if the steroids don't work in the office, then we proceed with a vitrectomy. There used to be, I should mention, years ago, a drug on the market that was an injection in the eye meant to close small macular holes. However, due to some side effects like vision loss, that drug has been pulled off the market. There is a role to observe some macular holes. So if a macular hole is very small, or if it's off to the side, if it's present, let's say in a lazy eye, or if it's associated with advanced retinal disease like macular degeneration, and we don't think closing the macular hole will improve the vision, then of course we observe these holes. So a vitrectomy to perform a macular hole is somewhat similar to, what I described earlier in that we perform a core vitrectomy. Oftentimes, the vitreous gel has not completely pulled off, and that's really the mechanism for the macular hole. It's a pulling of the vitreous on the center of the retina that created the hole. So we have to very gently lift the vitreous gel off the center of the retina and off. We remove the vitreous from the edges. We have to do a very careful exam to rule out retinal breaks at the edges of the retina intraoperatively, because there is an elevated risk when we remove the vitreous gel ourselves and induce a vitreous detachment that we can actually create retinal breaks in surgery. If it happens, it's relatively easy to fix. We just do laser, and we have the patient positioned postoperatively a little bit longer. But the important thing is to catch those retinal breaks if they form. Once those steps have been performed, then we draw our attention to the macula, or the center of the retina. Typically, I place a contact lens on the surface of the eye, which allows for a lot more magnification and good depth perception of the macula, the center of the retina. And using different instruments, typically microforceps, we gently remove any scar tissue that's present around the hole, and we actually remove what's called the internal limiting membrane in most macular hole repairs, which is the most superficial layer of the retina. And what that it allows for higher success rate in closing the macular hole. So you've removed the pulling, the front to back pulling, and you've also removed the side to side pulling, and you're making the edges of the macular hole more mobile and allows it to come together to close. Once those steps have been performed, you infuse air into the eye, then you do that air-gas exchange so that we leave the eye with a gas fill similar to retinal detachment repair. Now, positioning for a macular hole repair is face down. The reason being, when you're totally face down, the gas floats up against where the macular hole used to be, and it allows for like a scaffold. It allows the edges of the macular hole to come together and heal. Positioning varies based on surgeon preference. So face down positioning. It typically can be either completely face down, or the operative eye can be slightly up and face down in order for that bubble to be up against where the hole used to be. Face down positioning is very important for successful macular hole repair. Now, the good news is patients who are undergoing macular hole surgery usually have some heads up, unlike a retinal detachment that comes unexpectedly. So the patient can rent face down equipment, can come prepared, perhaps have family members assist for the week, that sort of thing. So we do have a little bit more control over the situation. I mentioned the success rate of macular hole being about approximately 95% or higher. Different types of macular holes could present with lower success rate. So you don't want a macular hole to become chronic, because then it does become harder to close. The macular hole can become larger with time. And sometimes we do achieve macular hole closure, but because the macula was had this defect for a long period of time, you may not recover as much vision. So it is important to present promptly. And it's also important for the patient once in a while to cover each eye and check vision in both eyes, because oftentimes if someone has very good vision in one eye, it may mask a big problem in the other eye. So it wouldn't be a bad idea once a week to close each eye and do a vision check and just make sure that things are where they should be. So yeah, pretty much covered macular hole surgery. And again, I'm happy to go over in more detail or answer any other questions towards the end. Moving on to epiretinal membrane. So epiretinal membrane is a condition that comes with several names. Sometimes we call it a macular pucker, cellophane maculopathy, a wrinkle of the retina, ER. B means around. So pretty much it's a membrane or scar tissue that has formed above the retinal surface, and specifically the macula or the center of the retina. The symptoms of an epiretinal membrane can be wavy lines. We call this metamorphopsia. So lines that should be nice and straight have a bend to them. Sometimes people will complain that words look too big or too small, or that the eyes are not working together because one eye has this epiretinal membrane and the other doesn't. Sometimes, and this is kind of a cue to me that a patient would benefit from vitrectomy, a patient will actually say that he or she has to close one eye in order to do up close work, to read something or to do some work. And that's usually a sign that the patient may benefit from a vitrectomy. Epiretinal membrane surgery is a little bit more of a gray area. So retinal detachment, I think, is a no-brainer. Generally, all retinal detachments should be repaired. Otherwise, the patient will continue to lose vision or even the eye. Full thickness macular holes almost always benefit from repair. Epiretinal membrane is one of these indications in retina in which it depends on how badly affected the vision is. So you have to weigh the benefits of surgery with the risks, the benefits of observing an epiretinal membrane versus operating. And my indication for surgery is generally that the activities of a patient's daily living are affected. So if the patient is having trouble reading or driving or seeing signs or watching TV, and we believe that this visual deficit is due to the epiretinal membrane, then it may be time to perform a vitrectomy. You may be wondering what causes epiretinal membranes to begin with. And once again, it falls on epiretinal membrane is, as the vitreous gel is pulling off the retina, it leaves a little scar tissue behind. So that is the most common cause for the epiretinal membrane. So oftentimes people have associated floaters with their membrane. Excuse me. There are secondary causes of epiretinal membrane formation, and it's important for the retina doctor to rule out these associated causes before proceeding with vitrectomy. So diabetes, once again, is a culprit and can cause epiretinal membranes. A blocked vein in the retina can cause it. Trauma, a retinal tear, treatment of a retinal tear, a history of blood in the eye, so on and so forth. So it's important to identify any secondary causes and treat those appropriately. If there's a pre-existing retinal tear, you would probably want to treat that before proceeding with a vitrectomy to remove the wrinkle. The diagnosis of epiretinal membrane is pretty straightforward. It's a combination of a dilated exam and an image called an OCT, which is a non-invasive test performed in the office, sometimes to look for secondary causes of macular pucker or epiretinal membrane. We will do intravenous fluorescein angiograms or dye tests looking for inflammation or a blocked vein, so on and so forth. The only treatment for a macular pucker is surgical. So if we decide, the surgeon and the patient together, that the pucker is worth removing, the management is the vitrectomy with a membrane peel. So you perform that core vitrectomy, you can shave the vitreous base, as we call it, remove that peripheral vitreous. Contact lens goes on the eye, and then using your microforceps, the macular pucker is removed. The great part about macular pucker surgery is that the vast majority of these cases do not require a bubble. There's no these patients tend to recover pretty quickly. In terms of the success rate or what you can expect from removing a pucker, I tell my patients that there is at least an 80% chance of obtaining at least a 50% improvement in symptoms. So that means the vast majority of people will get a significant improvement in their vision. It may not necessarily be 20/20. It depends on how bad the macular pucker was and what the starting vision is. But most patients are happy that they underwent the vitrectomy, and they feel that the improvement in their visual distortion was worth the surgery. As with most retinal conditions, it's good to not leave a visually significant condition to become a chronic condition. So you can operate on chronic epiretinal membranes. However, you can make the case that the vision may not improve as much as one would like, as opposed to a pucker that was worked on earlier. So if a macular pucker is visually significant and very bothersome, is probably best to address it at that time and not to wait several years in order to remove the pucker. Okay. So how are we with time? 2:30. Okay. I'm going to pick up the pace a little bit. Okay, vitreomacular traction is kind of on the spectrum of macular pucker and macular hole. So I wanted to briefly discuss that. It's pretty much the pulling of the vitreous distorting the center of the retina, not to the extent where a macular hole has formed, but there's enough disruption to the normal shape of the macula that the vision is distorted. Symptoms are wavy lines, blurred vision. Now, this condition can go one of several ways. So either the traction just spontaneously releases and the vision continues and a full thickness macular hole forms, which we discussed. Sometimes the patient is left with a partial thickness macular hole, which is generally not too disturbing to the vision. And sometimes the traction just stays the way it is, and it becomes chronic several months, in which case we may decide to do a vitrectomy just to relieve that traction. And again, this is one of these gray areas. It depends on how much pulling there is and how bothered the patient is by the vision. Okay, a big topic is diabetic retinal disease. I had mentioned that this is one of the more common causes for visual impairment in the middle-aged population. It's very important that all diabetics at a bare minimum get yearly exams, sometimes more depending on the extent of the diabetic retinal disease. It's very important that the patient has good sugar control, blood pressure control, cholesterol, that they avoid smoking, so on and so forth. What people don't realize about diabetes is that a patient can have 20/20 vision and very advanced diabetic retinal disease. And unless a doctor is doing a good dilated exam, the patient can be unaware that there's a problem until an advanced complication develops. So briefly, I'll discuss four conditions of diabetic retinal disease that are resolved with a vitrectomy or retinal surgery. There's vitreous hemorrhage or blood in the eye. If you recall, the very first vitrectomy in the United States was performed for non-clearing blood in the eye. Generally, we first try injections in the office and laser. However, if bleeding persists, or if the patient only has one eye, or if they're really bothered by their vision, or if it's a recurrent bleed, then doing a vitrectomy for non-clearing blood is reasonable in order to hopefully decrease the risk of recurrent bleeding. I mentioned epiretinal membrane formation in diabetics, and we would address that typically the way we address other epiretinal membranes, as I had just reviewed. Tractional retinal detachment we discussed, and these cases can be a little bit involved, and it's important that the patient present promptly with any sudden vision changes. And then lastly, we have the kind of most advanced stage of diabetic retinal disease, which is when you could have bleeding in the eye, you have the active diabetic retinopathy, the scar tissue, and a macular hole. These cases can be on the order of 2 hours or so. The patient's asleep, and we do all the things that I had discussed. So macular hole repair, diabetic retinal detachment repair, laser, typically or definitely gas, and postoperative positioning. Okay. Next, I wanted to just spend less than 5 minutes talking about complications of cataract surgery. So unlike retinal surgery, everyone has heard of cataract surgery. You've either had cataract surgery or you know someone who's had cataract surgery. Cataract surgery is one of the most commonly performed surgeries in the United States, and it goes very well in most cases. However, I wanted to discuss about 5 indications of retinal surgery as a result of a complicated cataract surgery. So uncommonly, as the cataract surgeon is removing a cataract, a piece of the cataract can fall to the back of the eye. So we call that retained lens fragments. If it's a small lens fragment, sometimes observation alone is sufficient. We put the patient on drops for inflammation, sometimes elevated eye pressure, and the retained lens fragment can dissolve. However, if it's a big enough piece, also what's called a lensectomy to remove the cataracts. Second issue that can happen is the retinal surgeon may have to put an artificial implant in place. So for whatever reason, the patient is left without an intraocular lens implant. So typically as part of cataract surgery, the surgeon will remove the cataract and put a lens implant in its place. However, if for whatever reason the cataract surgery is complicated, or if there's trauma and the lens falls to the back of the eye, history of vitrectomy can increase the risk for the lens dislocating, then sometimes the retinal surgeon will go in and remove the intraocular lens that's fallen to the back, or if there was never an intraocular lens placed to begin with, the surgeon may then place an intraocular lens. And there are different parts of the eye that the intraocular lens can be placed. And there are pros and cons to all of these approaches, and I'd be happy to go into more detail in the question answer session. Retinal detachment is sometimes a complicated factor after either smooth cataract surgery or complicated cataract surgery, and of course, we discussed that earlier. Endophthalmitis is an infection of the eye that is extremely rare. It is not specific to cataract surgery. It can actually happen after any type of incisional surgery of the eye. So it's very important that patients present immediately with any concerns of pain, red eye, floaters, blurred vision, pus, eyelid swelling, anything out of the ordinary after any type of eye surgery needs prompt attention. Endophthalmitis or infection of the eye can be treated medically in the office. However, if it's severe enough, the retinal surgeon would perform a vitrectomy into the eye. And this is actually one of the few true emergencies in our field. So I always advise people after any type of incisional eye surgery not to get water in the eye, not to go swimming, not to rub the eye, not to wear contact lenses. You want to avoid dusty, dirty environments, and hopefully this rare complication would be avoided. Lastly, some patients will develop swelling of the macula after either routine cataract surgery or complicated cataract surgery. It's probably more common than we think, but most cases of this macular swelling resolve on their own. However, if a patient starts to develop blurred vision about a month after cataract surgery, 4 to 6 weeks, it could be this inflammatory condition. Generally, we can manage it medically in the office with steroids, either in drop or injection form. Very uncommonly would we do a vitrectomy to remove the inflammation and to remove the vitreous, which is sometimes the culprit if the vitreous is not where it's supposed to be, and then that hopefully improves the inflammation. Okay, the last two surgical indications, I'll be very brief. Trauma, hopefully no one experiences severe trauma that requires surgery, but if blood develops as a result of trauma, dislocated lens, retinal detachment, or a foreign body in the eye, these can be indications for retinal surgery. The last indication are tumors. So I won't talk about this much because I am not an eye cancer specialist. I diagnosed cancer, but typically we will refer these patients to an academic center either in Philadelphia or in Baltimore. There's no retinal surgeon who is oncology trained in Lancaster. Fortunately, these tumors are very rare. They could either come from the metastases from, let's say, a lung cancer or breast cancer. And these are sometimes treated medically, but they can also be treated surgically by a trained eye cancer specialist. Okay. Recovery of retinal surgery depends again on the indication. I mentioned some are really quick. Patient can be back to work within 48 hours. If you have the gas bubble, you have restrictions, you have positioning for up to 2 weeks. Generally, the discomfort is very manageable. Any concerns need prompt attention. There are always risks to surgery, as you could imagine. Risks to vitrectomy. I always tell patients the very bad complications are very rare. You may have inflammation, which is usually managed with drops. Elevated eye pressure can typically be managed with drops. Low eye pressure is uncommon, but can be encountered. Bleeding complications hopefully are minimized with good surgery, avoiding heavy lifting, and discontinuing blood thinners at the appropriate time. There could be, especially in glaucoma patients, damage to the optic nerve. If a glaucoma is very advanced, I will generally steer a patient away from elective retinal surgery. If the surgery needs to be performed, I usually bring the glaucoma specialist on board and make sure the glaucoma is under optimal control before vitrectomy is performed. Scleral buckle comes with some very uncommon, unique risks such as double vision or exposure of the buckle. It's very important not to rub the eye so that the eye heals nicely with the scleral buckle in the right position. Those are predominantly the risks. Cataract deserves a little special attention. So cataracts get worse after a vitrectomy, and this is more of an expectation rather than a complication. So if they're 50 years and above, there is a 50% chance that they will be obtaining cataract surgery within 1 year of a vitrectomy and 90% chance within 2 years. So there's something about removing the vitreous gel that changes the way oxygen is metabolized in the eye and leads to oxidative damage and cataract progression. But those who have had cataract surgery, of course, don't have to worry about that issue because cataracts do not recur for a second time. Okay. My last point of discussion, I'll try to keep this at about 5 minutes or less, is the future of retinal surgery. So of course I don't have a crystal ball, but I can tell you that in the 10 years, I've been out of fellowship now for a little over 10 years, I have seen a dramatic improvement and evolution of this exciting microsurgical field in just 10 years. In terms of the size of the instrumentation, when I was a fellow at Penn, I was actually still doing some 20 gauge vitrectomy, which had been going on for decades. Within my fellowship, I then started to do 23 gauge vitrectomy, which is using smaller instruments. And then 25 gauge vitrectomy came out, and now we even have 27 gauge vitrectomy. This is real microsurgery. Not only are the instruments getting smaller, but the vitrectomy itself is getting faster. So the vitrector or the cutter that I mentioned several times used to function at a cutting speed of 5,000 cuts per minute when I was doing my fellowship. Now we have vitrectors out there that cut 30,000 cuts per minute. This is a remarkable speed. It not only allows surgery to be faster, but it actually makes surgery safer because there's less pulling on the retina. The fluidics have improved. And complications. So these are all really amazing advances, and again, a very short period of time. The viewing systems have improved. So again, when I was a fellow, not that I've been out for that long, but the viewing systems were a contact lens on the cornea, and an assistant would have to hold for the entirety of the case. Now we have viewing systems that go out. You can see the entire retina without any assistance from your scrub tech. So this is also very nice, makes for safer surgery. Gene therapy is making its way in retina. And actually, when I was a fellow at Penn, we had several experts on faculty who developed the first FDA-approved gene therapy for a very rare retinal condition, cause of blindness in pediatric population. Since then, gene therapy is in phase 2 and 3 studies, not just for the rare genetic retinal conditions, but now for very common conditions such as macular degeneration and diabetic retinopathy. So scientists are looking at incorporating the VEGF inhibitors, which are the injections we give in the office, into a gene product that we would then insert into the eye by way of surgery and would be continually produced by the patient and hopefully would eliminate the burden of monthly eye injections in the office. So again, these are still in studies, but in the next few years, hopefully we may see gene therapy as a potential solution to these chronic conditions. There's also port delivery systems which have been developed again to decrease the burden of the regular eye injections in the office. There are currently 2 systems out, one to treat diabetes and wet macular called Susvimo, which came out by Genentech, and then another port delivery system to treat a relatively rare condition. This is in a system called Incelto, which was just approved this year. Now, of course, we need long-term data. I mean, this is different in that it's a chronic implant in the eye. So it'd be nice to have more long-term data. But again, it's exciting to have an extended drug delivery system to treat these conditions. Amazingly enough, and I'm headed to the home stretch here, in the New England Journal of Medicine, just last week, Moorfields Eye Hospital, which is a premier eye hospital in London, just published their retinal prosthesis, which would be a way for patients with advanced loss of tissue due to macular degeneration predominantly, a way to help them see better. It's a very complicated technology that involves a vitrectomy and a microchip implanted under the retina. The patient would wear glasses with a camera, and then that camera and glasses are attached to a computer worn on the waist. And basically, information from the outside would then be processed by the camera by way of this computer, and then delivered to the microchip using infrared light. The microchip then converts the light into electrical signals that go to the brain, and then the brain learns to interpret these forms. And so basically, from a clinical standpoint, what the researchers reported was that about 80% of people developed more clinically useful vision. They went from being legally blind to apparently being able to recognize numbers and letters. So it will be interesting to see if this gets approved in England, Europe, and if we get similar results here in the States. I think I'll end there. Still being worked on. We have corneal transplants, but we don't yet have stem cell and whole eye transplants. Hopefully one day in the future, currently in clinical trials with the stem cells. So thank you for your attention. I may have gone over time, but I think we covered a lot of ground, and I'd be happy to answer some questions at this time. So thank you very much.
Thank you again, Dr. Gewaily, for presenting to us on surgical solutions for retinal disease, improving vision and quality of life. And before we open the questions and answer session, again, just to remind everyone, if you're not yet a client of Vision Corp or participating with us at Vision Corp, we'd love to talk with you. You may reach out to Steve, whose information was on the flyer, or you may certainly reach out to us at the rehab department at 717-205-4141. We have a lot of wonderful rehab services in addition to these types of community presentations, including low vision occupational therapy, safe travel instruction, access technology instruction, case management, support groups, adjustment to vision loss, and many more. So we'd love to talk with you more about that. So I'm going to turn it over to Taylor, who's going to help facilitate our question and answers. Thank you.
Thank you.
All right, if anybody does have a question, now would be a time that you can unmute yourself. And if there's more than one person at a time, we'll just go by the first few numbers. I see somebody with the last four numbers of your phone number, 4861. You are unmuted. Did you have a question?
Yes, this is JB, and I had a question for the doctor. I am interested in any therapy that might be coming along with a retina replacement. When I asked Gemini AI bot, they said that was already available at Wills Hospital and I believe someplace in Baltimore. Is that correct?
So I know Wills Eye Hospital is participating in stem cell trials. So if you are interested in trials, they may still be enrolling. The retinal prosthesis that I had mentioned was just the group in England just published a paper, is not yet available in the States. Years ago, there was a similar technology, but then it came off the market due to various reasons. So as far as I know, there is no retinal prosthesis and there is no replacement, but it is definitely in trials. The important thing is, though, please do not go to a random unauthorized stem cell clinic, which does exist, because that can lead to a lot of complications and vision loss. But if you are interested in trials and I obtain your contact information, I'd be happy to get back to you with such information.
Sure, I can give it to you.
Okay, well, let me write it down. One moment. Okay, is
Maybe
it okay if I take down or later?
Well, yes, maybe once we're done recording, then we don't
Okay.
have that
sure, yeah.
information out there.
Okay.
So we could, if you don't mind, JB, we'll just wait till the end and we will definitely get you in contact with Dr. Gewaily, okay?
Okay, great. Thank you.
You're welcome. All right. There was somebody with the last four digits being 5490. If you would like to unmute, if you still had a question. If not, I will move on to the next one. All right, go ahead. I have someone with 8144. If those are the last four digits of your phone number, I see you're unmuted. You're welcome to ask your question.
That's me. This is Norma. I'm interested in knowing about macula dragging. That's what they told me I have. My macula is dragging, which causes disturbance in my vision, and then it clears up, and then disturbance again.
So if there's macular dragging related to a pucker or the scar tissue epiretinal membrane that I discussed, then that is definitely amenable to surgery. I would imagine someone would have told you, though, if there was an epiretinal membrane that was causing the dragging. If, however, the dragging is due to a disease, retinopathy of prematurity, like if you were born
Yes,
premature,
that's it.
okay. Yeah. So unfortunately, that may not have a surgical solution at this time, unless again there is a concomitant pucker that can be peeled. But I imagine if there was a pucker, they would have sent you to a retina surgeon. So at this point, I would just make sure that the retinopathy of prematurity is being monitored, that you're not developing complications, that you make the most of the low vision services that Vision Corps has to provide.
Mm.
Yeah.
Could it cause retinal detachment?
It can. So, retinopathy of prematurity patients can develop retinal detachments later in life. So, you definitely want to be mindful of the retinal detachment precautions. If you were to notice floaters, flashes, a curtain, then you definitely want to give your eye doctor a call within 1 day. That is a
Hmm.
very important point.
Okay, thank you very much.
All right.
4057 is back.
Okay. All right. If you would like to ask your question, please go ahead.
I have what they call myopic degeneration
Mm-hmm.
due to not being able to see distance. And the treatment of choice long ago was laser on the one eye and then injections in the other. And they developed scars. The laser treatment was created right in front of a scar right in front of my retina. And the
Mm-hmm.
other eye is injections, and they're hit or miss everywhere. Now, I was
Yeah.
told that there's nothing they can do for that unless they develop stem cell because the tissue underneath the scarring is dead. Is that correct?
Yeah, that's probably correct. So you probably obtained laser before shots were even available. So shots really
Yes,
only became a thing in 2005. And now
right.
we try to avoid laser in really nearsighted people because of that increased risk of scarring. Laser is a destructive procedure, especially in the center. So it's now we treat myopic blood vessel formation with shots. It shouldn't be
Yes.
hit or miss in your other eye. I mean, you should have stable vision in the other that's receiving shots.
I have scarring where the
In
bleeding was.
Oh, okay, okay.
And so it affects like my vision as far as numbers and letters.
Mm-hmm.
If there's a 569, I only see the 69.
I understand. Yeah, so you want to definitely continue to monitor your vision. If you haven't heard of an Amsler grid, you should have one. If you notice
I have
changes on the
one.
great. So if you notice changes on the grid, you definitely want to call your eye doctor promptly because at least we want to keep the scar as small as possible. We don't want another severe bleeding episode that's going to make that scar bigger in your good eye. But
No, I see her every
yeah,
4 to 6 months, and they do
mhm,
pictures and all of that. So
okay.
they're keeping a close watch on because it's my only eye that's good.
And when was the last, if I could ask, when was your last injection?
My last
Do you recall?
injection, let's see. She did one because they thought they saw bleeding, but that was like maybe a year ago.
Okay. All right. I mean, we have to trust the doctor's judgment, 4 to 6 months. Sometimes that interval is shorter, especially if you're treating as needed and you only have one good eye left. But
Right.
you follow your doctor's advice. And yeah, at this point, we just have to hope for stem cell therapy or that retinal prosthesis to come, to get approved and to help folks like you. And of course,
Right.
you would ask your low vision specialist, Vision Corps, if you'd benefit from, one of their aids in the meantime.
Yes.
Yeah.
Are they working on stem cell at all?
Yes, yes. So I'm sorry I rushed through that last part because I realized it was way over time. But yeah, it is definitely in studies, phase 2, phase 1 studies. Locally, they're working on it in Philadelphia, I believe. So yes, the moment stem cells become available, you will know about it. So it's currently
good.
being in studies. Yeah.
Okay. Well, thank you.
No, thank you.
All right. Phone number ending in 0292. If you have a question, go ahead.
Hi, my name is Maria. I've had retinal detachment and I've lost my vision on my right eye, and on my left eye, my retina is fraying. Now, what can be done for that?
I'm sorry, what did you say is the status of your left eye?
My left eye, my retina is fraying because I have long eyes. I don't have normal eyes. And what's happening is my eye is pulling on my retina.
Uh-huh. The vitreous is
And
pulling,
my,
yeah.
yeah.
Mm-hmm.
So what can be done for that, doctor?
Okay, that is a good question. It depends on the degree of pulling. So, and if it is amenable to surgery. So if you're the pulling is distorting the center of the vision or the retina, that would be a reason to do surgery. Yeah, people debate in very nearsighted people when is the right time to do surgery. And you take into account the pictures, the complaints, the vision. So it would require like a detailed exam and discussion to see if you would be a surgical candidate in your only eye. But there's always risks to surgery, so you have to weigh the risks with the benefits.
Right.
Yeah.
But because I have center vision, I
Uh-huh.
mean I can see, but
Yeah.
how I see is like a cloud, like I have this fog, and it's I know it's because of the retina, because there's that fraying of the retina. Yeah.
Yeah.
And
Yeah.
I'm getting injections, just to control it so it won't progress. But I'm seeing that it's progressing.
I see. Yeah, I guess the doctor would have to determine if it's progressing due to the abnormal blood vessels for which you're getting shots for, or if it's more of a surgical issue. So
Okay.
yeah, that is a good question. I would have to see your pictures and exam to make that determination. But you'd have to discuss with your doctor to tease out what's what. But the shots
Okay.
are serving a purpose, it seems. Yeah.
Yeah, I would like to see you to get a second opinion besides my doctor, so you can see.
Okay, yeah, I would be happy to see you. Yeah.
So where are you located at? Are you at 2150?
2150 Harrisburg on LGH, the health campus, 3rd floor.
Okay.
Yeah.
Okay. So I'll be seeing you. Thank
Okay,
you so
great.
much for
I
your
look
advice.
forward to seeing you.
Okay.
All right, Cecilia, I believe you have your hand raised.
Yeah, I was wondering, my computer, the battery died right about the time when I think soon after that you were talking about macular degeneration. So I don't know if you talked more about that, but my family, my dad had it and my sister has it, is developing it. And I have another friend who has it. And I was wondering, do you do those kinds of things too, or is that a different kind of specialist?
No, that is most of what I do. So retinal surgeons are not typically in the operating room every day. We spend most of our time in the office giving shots, and most of our conditions have medical treatments. It's just I happen to focus on the surgery for my talk, but no, we treat lots of macular degeneration. Yeah.
So,
and depending on the type, sometimes it's observations, sometimes it's injections. Depends on the type of macular degeneration.
do you think you'll ever have a talk on macular degeneration?
Didn't I have one already?
Oh, did not. Shoot,
Yes,
I
a
can.
few. We do have other recordings available from your prior presentations that we're happy to share.
Thank you.
And
Absolutely.
I'm happy
You're
to give another
welcome.
one because again,
Oh,
it's
yeah,
a
we'll
fast
do it.
evolving field. So yeah,
Thank you.
you're welcome.
All right, I'm not currently seeing anybody else with a question, but I will give another couple seconds here to see if anybody does unmute. All right, 2339, if you have a question, go ahead.
I do. Hi, this is Susan. I'm new to macular degeneration. I'm getting the shots every 2 weeks. I don't know what kind of macular I have. The doctor hasn't said anything.
Mm.
Can I infer what kind?
Are you
Can
getting
you?
alternating
Izervay.
eyes? Okay. Izervay is probably being given every 2 months.
Oh, that's what I meant to say.
Okay.
Yeah.
So
No.
yeah, it's okay. Izervay is for dry age-related macular degeneration.
Right.
Or rather, I should
right.
be specific. It's for geographic atrophy, which is loss of tissue, which can be found in either dry or wet AMD. But if you're not
Okay, I
getting
have
any
dry.
other, if you're not getting any other injections and it's just Izervay, you probably have dry AMD.
Would I be a candidate for this surgery?
It depends. Which surgery are you referring to? The vitrectomy?
Any
Any
you mentioned the different categories, but I didn't know what category I was
Right.
in.
So at this point, we don't perform surgery for dry AMD. I mean, if you have atrophy, hopefully one of these future surgeries may benefit you. You know, what's in the pipeline, the research, if you were to qualify. But right now, there is no surgery for dry AMD that is approved in the United States. It would be one of two drugs, either Izervay or Syfovre. And other drugs are being studied, but those are the two that are currently approved for dry AMD, and they're injections.
Okay. And if, do you advise people to maybe hold off a little longer to get any kind of genetic fixation, or would it be better to get surgery whenever that's available?
I'm sorry, to hold off on genetic testing? Is that what you asked?
Not, no, what were you talking about?
Oh,
The
gene therapy. Gene therapy. It's still not approved. These are still being studied. So
Okay.
hopefully gene therapy will eventually be available. Being studied for wet AMD at this time, not for dry that I know of. But at this point, we don't yet have gene therapy for AMD that is approved. Yeah.
Well, I think my vision's getting worse, but all I'm getting are the shots. There are no other alternatives right now, correct?
Unless you want to participate in a study, there is nothing approved surgically for dry AMD, just the shots to try to slow the growth of atrophy. And of course, take advantage of all the low vision resources you have at Vision Corps to help you maximize use of your peripheral vision, because hopefully you will always have your peripheral vision.
Right. Okay. Thank you so much. It was a great talk.
Oh,
Thank
good.
you.
Thank you. Thanks.
Thanks.
Can I hang up?
Yeah.
All right, I think 5997.
I have a question that might be a little off point, but here it is. What is the functional difference between the retina and the nerve?
That's an excellent question. So basically, the retina is the back lining of the eye, and all the retinal cells converge and onto the nerve. So the nerve I compare to a cable. It connects the eye to the brain. So the retina gets the light. It converts the electrical signals through the nerve to the brain. And different diseases affect the nerve and different diseases affect the retina. but you need a good nerve and a good retina to have good vision.
Thank you.
Thank you.
All right, so at this time, we appreciate everybody's questions. Those were great. Dr. Gewaily, again, thank you so much for your presentation. Very, very informative. We've got a lot of feedback coming through the chat. If you were not able to see it, everybody there is also saying thank you. So we appreciate your time. We appreciate your knowledge. And there was a gentleman who wanted to share information, so maybe you stay on as everybody gets off, and you could just briefly share your information with Dr. Gewaily then, so that's a little more private. But for now,
Yes.
have a good rest of your day, everybody, and stay tuned for the next VC Presents. Thank you.
Thank you for having me.
Hello, doctor?
Yes, hi.